Good afternoon, and thanks very much for sticking to the final session. I'm Tom Hennell, and this is Emma. I will be providing a bit of context. Emma will give us the detailed findings, and then I'll follow with a sort of discussion. There's now trying to. Great. Our context is this data set, which has been produced for us and released by the Office for National Statistics. Whoops. There we have it. We are reporting on this. It was released in December 2022. And it gave us a list of people who have been identified both with cardiovascular or respiratory conditions or with poverty as estimated with an ONS model, and counted and local areas and middle super output areas. And then they provided additional data in May, which provided the same information at the local level, but with indirectly standardized rates. Still not getting anything. Sorry. I'm starting. I'll just do that. Sorry, can I have the clicker? Yeah. Makes life easier. Right. So we've been, and this is available because with increasing costs of living, we were getting lots of requests from health partners for data about vulnerable cohorts that was granular, that was timely, and picked up people with the specific health conditions of interest. And our thanks are due to the ONS team, who also reported in this room an hour ago. So well done them. Now, in addition to providing a valuable resource that we are wanting to evaluate in terms of cost of living pressures, it also addresses a couple of long-term issues that we had always been likely to worry about. One is the question of attribution. When we attach, say, worklessness or deprivation to health data, we attribute from the local area, and we all do it all the time. And we assume that that's valid. But is it? Another one is the question of recovery from chronic illness. When we look at chronic illnesses, we assess them either as point prevalences, people who are ill at any one point in time, or period prevalences, people who have become ill over a considerable period of time. When we look at primary care records, all we can see are the period prevalences. We can't tell for the people who've been diagnosed with illness whether they're still ill or whether they've since recovered. But does it matter? The ONS series potentially allows both. It allows us to look at poverty without attributing from deprivation quintile. It allows us to look at specific diagnoses, which in the ONS data set are effectively period prevalence, and cross-check those against what we see in the census. And that tells us, for instance, how many people with chronic heart failure have since recovered. What percentage might that be? Have a guess in your own mind, because we now know the answer. It's 37%. 37% of people who had been reported with a diagnosis of chronic congestive heart failure since 2000 were in the census not reporting themselves as ill, that is, affecting illness or condition affecting their ability to undertake daily life to any degree at all. And these are the conditions picked up in the ONS series, and we can see that almost all of them, the recovery rate is higher than 27%. And indeed, that's likely to be an underestimate because some of these people will have been ill from something else other than the condition that we have recorded in the ONS series. I'm now going over to Emma.
Thank you. So I'm just going to talk a little bit about the methodologies of our analysis. So as I mentioned before, ONS wonderfully matched over 50 million individual responses, which includes most of the England household population. We then selected rates for almost all the England NSOAs unchanged from between 2011 to 2021 for an ecological analysis. There were some outliers, however, and this was due to populations being served by GPs that were not reporting to the GP extraction service. So we've taken 3 series from the ONS second release, presenting age standardised rates for household residents and logged them. We also took household data for MSOAs for the 2021 census and also population outcome standardised rates. That was from time period 2016 to 2020, and that was from local health. And we then analysed the association for the ONS series using multiple regressions in R. So these are for our regressions. We selected 2 main series from ONS. This included poverty and historic conditions. We used them separately. We didn't use the combined indicator, and this is because we just lose too much data. For our dependent variable, we then use under 75 mortality, and this we didn't use over 75 mortality. This was because ONS looks at household figures, and if we looked at over 75, it tends to be skewed at MSOA level, so we couldn't use that then. And unfortunately, we couldn't use the emergency admission rates, and that's because there was some overlap between the local health data and then the ONS level data as well. So I'm just going to go through a few of the plots. This first one presents the 2 ONS series that we use, so that's standardised poverty against standardised chronic conditions. As you can see, there is an association, but it's not very strong at all. You can say that less than 20% of the variation in chronic conditions can be explained by poverty. However, this is obviously very weak, so it does mean poorer people can get ill with a heart or lung condition, however, compared to more affluent people. However, it's not very strong at all. So here we're looking at the plot for chronic condition against premature mortality by all cause and also by circulatory conditions. Again, this is stronger than the previous slide, however, still very weak overall. And finally, the strongest of all, we're looking at associations between ONS standardised poverty and also our 2 premature mortality ratios. So more than 50% of the variation of premature mortality can be explained by poverty. And finally, here is the regression model that we did in R. So we looked at premature mortality model and also the cardiovascular and respiratory conditions model. So when looking at premature mortality, the explanatory terms that we looked at interest included ONS models household poverty logged, census household limiting illness logged, and ONS estimates for cardiovascular and respiratory conditions prevalence logged. And it gave an R-squared value of 0.74. For the other model that was for cardiovascular and respiratory conditions, we found explanatory terms of interest, including census data, so for social housing logged, census data for no passport, but that was not logged, and census data for never worked logged, and that gave us an R-squared value of 0.53.
Right, so a few conclusions for discussion. One is this is a really, really good data set. Much better for poverty than using, for instance, the income term from the 2019 IMD. It's more timely, it's more granular. We reckon that you should use the directly standardized version. We reckon that you should use the conditions and poverty separately, not the combined count of people who are both with a condition and poor. The wider context on the question of attribution, this really is something that we should be doing more of. We shouldn't be doing attributing across, we should be looking as far as possible for ONS to be developing further, though obviously subject to conditions of disclosure control. But there are some wider points. This is the traditional way in which we have understood the wider determinants of health. This comes from the global burden of disease and is assumes causes of the causes of the causes, that things work through the metabolic, pathogenic microbiomes to morbidity, to mortality. But the global burden of disease study has never actually quantified the outer terms of their model and their relationships. But now we can. We have got poverty, we've got historic diagnoses, and we've got under 75 mortality. And the relationship of poverty to diagnoses is weak. The death relationship of diagnoses to mortality is stronger, but much stronger still is poverty and mortality overall. It is a conundrum because the overall chain is a great deal stronger than the individual links of the chain. And it's the same when we're looking at circulatory mortality alone. So we need to rethink things. And if we make a broad assumption that the death only happens to people who are ill at the time, we can make a general assumption, a simplification, that the global burden of disease is new illness or incidence plus recurrence times duration times a functional degree of burden. And the general assumption in health inequalities policy has been that the wider determinants of health act on the left-hand term. That the reason why poor people spend more of their life in illness than rich people is because they become ill more frequently. But now we know they don't. What we now know is that it looks like the right-hand terms. What's the difference that we're observing in health inequalities comes from differences in recurrence and differences in duration of illness. That implies two distinct agendas for public health, a prevention agenda and a recovery agenda. And so I'm proposing an extended causal web, taking the GBD version, but terminating it just in onset of illness. But then adding on to it a separate path that goes directly from social, cultural, and economic to differential access to recovery through the mediums of access to health assets and discourses of reciprocal trust. You'll notice that the GBD version is physical and medical, but our recovery version is not. That is based on the observation, which we find from Gavin Francis, that the primary virtue that drives recovery is trust. And therefore, we are seeing that our trust is access to trust is what is distinguishing our health assets. And that leads, we observe, to two different distinct components of mortality. An acute component, which is the risks are highest from chronic illness immediately after you have been diagnosed, and a long-term associated with persistent non-recovery. Thank you.